now. So welcome everybody to the VASCERN webinar, a diagnostic and management pathway for severe and or rare infantile hemangiomas. Our presenter today is Dr. Andrea DIOCIAUTI. Next slide, please. Before we start, I'd just like to go over a few basic general instructions. So just so you all know, the webinar will be recorded. In order to avoid any disruption, if we ask you please to type any questions in the chat box, that way at the end of Andrea's presentation, we'll be able to answer the questions. And if you have any technical issues, any problems, please either type in the chat box or you can send us an email to myself and we'll try to assist you. Next, please. So just very quickly, for those of you who don't know, VASCERN, we are one of the 24 ERNs. We are the ERN, the European Reference Network on Rare Multisystemic Vascular Diseases. So our ERN gathers 26 healthcare providers, full HCP members, plus we have 7 affiliate partners, and they're all coming from 16 EU countries. We also have over 70 patient organizations from across Europe that are, make up the European Patient Advocacy Group. Our network is divided into 5 rare disease working groups. So we have the HHT working group, which is the Hereditary Hemorrhagic Telangiectasia working group, the HTAD working group, which is the Heritable Thoracic Aortic Diseases working group. So they cover diseases like Marfan syndrome and Loeys-Dietz. The medium-sized arteries working group, and they cover Ehlers-Danlos syndrome, the vascular type. The PPL working group, which is the Pediatric and Primary Lymphedema working group, which cover a variety of rare diseases dealing with lymphedema. And finally, the VASCA, the Vascular Anomalies Working Group, which is the group from which our presenter today is a member. They cover more than 40 rare diseases, all to do with vascular anomalies. And next one, please. So today's presenter, as I mentioned, was Dr. Andrea DIOCIAUTI. He is a dermatologist from Bambino, Gesù Children's Hospital in Rome, Italy. So welcome to Andrea, and I'll pass it to you now.
Thank you, Natasha, for your kind presentation. So we will talk about the diagnostic and management pathway for severe and rare infantile hemangiomas. A few words about VASCERN, that as we know, is a network, European network on rare multisystemic vascular diseases that is dedicated to gathering the best experience in Europe in order to provide accessible cross-border healthcare to patients with rare vascular disease. And the surprise is that the rare patients are 1.3 million in Europe. So it is true that rare are many. It is coordinated in Paris, and in particular from Professor Guillaume Gendot. This is the VASCA working group. It is coordinated by Mika Vicola, Lars Boon, and Leo Schutz. This is one picture during one of our annual meeting. As you see in the picture on the left side, in the center of all the working group, there is the patient advocacy group. It is very, very important to remind every meeting that is a patient-centered project. And now about infantile hemangioma. They are benign vascular tumors of infancy. They have 3 phases: a rapid growth in the first weeks of life, stabilization, and then spontaneous regression. In rare case, the extent, the localization of the tumor and the number of the lesion may cause severe complication. So we defined severe infantile hemangioma as being or life-threatening, for example, airway obstruction or liver or cardiac failure, with risk of functional impairment based on the localization, and in case of severe pain, especially in case of ulcers. Ulcers may be very, very painful and resistant to standard treatment. And or in case of significant and permanent disfigurement, as in the picture you see on the right side. And our definition of rare infantile hemangiomas includes large segmental hemangiomas. Usually in literature, there is a definition of 5 centimeters, especially on the face, to define a large hemangioma, and syndromic variants associated with extracutaneous abnormalities. Prior our pathway, there are publications mainly focused on propranolol treatment and the consensus statement for the management of rare infantile hemangiomas, mostly focused on FACE syndrome. The aim of the VASCA working group is to produce an opinion statement reflecting strategies put forward by experts and patient representative on how to approach patients in a practical manner, providing an algorithmic presentation of the results. The methods are based on the principle that decisions from a group of experts are better than the opinion of a single expert. And we use the nominal group technique. There is a well-established structured multi-step facilitated group meetings technique used to generate consensus statements. The pathway was drawn within 2 face-to-face meetings between March 2018 and October 2018, multiple video conference meetings during 2018 to facilitate the discussion, and also by mail. The mail was very useful also to avoid the group dynamics. For example, if you have a very authoritative group member that could drive the pathway and the discussion. And we have 2 facilitators. The one is a dermatologist because of the particular experience of this specialty in this field, and it was me, the dermatologist in this case. And the chair of the discussion, that was Mika Vikula, is one of the coordinators of the group. The chair of the group promoted the inputs from all the members, continuously stimulated inputs, and summarized all the options and the decision and the reason of choices, and identify common grounds. But further decision points were proposed also by the group, and the best choice were discussed within the panel of the experts. Conflicting points were further discussed until the conclusion was unanimously agreed. There was no time limitation, and the final face-to-face meeting was set up in March 2019 to validate the final draft that was then published as an open access on the website of the VASCERN. This is the legend of the pathway, so clinical evaluation, investigation, treatment, and particular cases in different colors, as you see. And then we start. We have a patient with infantile hemangioma, or we suppose to have an infantile hemangioma. It could be a superficial lesion or a deep lesion. If there is no clinical evidence of the lesion because it's a deep lesion, or if the clinical of the lesion is superficial, but we are not sure about the nature of the lesion, so there is no clinical evidence, then we have to make some more assessment. But before, in the case of clinical evidence, we can have focal infantile hemangioma, multiple infantile hemangioma. An important limit is the number of 5. When you have 5 or more infantile hemangioma, is important to decide as a decision point to make other examinations, and segmental or large indeterminate infantile hemangioma. These are the 3 forms of infantile hemangioma. And but if you don't have a clinical evidence, you have to perform Doppler ultrasound. Doppler ultrasound is the first step of radiological examination, because is not invasive, and also is very useful and give a lot of information about the flow. If there is fast flow, slow flow, and then we can have a confirmation of infantile hemangioma or no evidence of infantile hemangioma. Then we will see after what to do. When you have a focal infantile hemangioma, you have to evaluate the risk of functional impairment, the airway obstruction, for example, the presence of ulceration, and the risk of disfigurement. When there is multiple infantile hemangioma, we have to evaluate the same points, but also we have to perform hepatic ultrasound, because more than 5 or more infantile hemangioma may be associated with hepatic hemangiomatosis. So hepatic ultrasound is very useful to confirm or not the presence of infantile hemangiomas in the liver. If you don't have, you go on the same points you have to evaluate when you have a cutaneous infantile hemangiomas. Otherwise, if you have hepatic lesions, you have to distinguish if you have signs of hemodynamic effect or not. If there is hemodynamic effect, you need a cardiological evaluation. Then, in the case of segmental or large indeterminate infantile hemangioma, indeterminate is when you cannot decide if it's a focal or a segmental, so it's something between the two forms of infantile hemangioma. In this case, you have to check the phase criteria. So you have, it's important to refer the patient to an expert center, of course. It's important to perform an MRI and the angio MRI to study the cerebral vasculature, and you have to perform ophthalmological consultation to search for eye malformations, and also to consider endoscopy of the upper airways, especially in the patient with the beard distribution that is very highly associated, especially in presence of symptoms, with obstruction of the upper airways. And when the segmental hemangioma is localized on the of the lower part of the body, especially if it's lumbosacral or in the genital area, we have to perform ultrasound from an expert radiologist and or magnetic resonance in order to search for associated anomalies and exclude pelvis, lumbar, sacral. They are all acronyms of the same entity. Nowadays, we prefer to use the lumbar acronym. There is lower body infantile hemangioma or other cutaneous signs associated, urogenital anomalies, myelopathy, bone deformity, anorectal abnormalities, and arterial and renal malformation. This is the acronym to define this particular condition. When there are, that is mandatory also. If the ultrasound is not sufficient to assess the patient, you have to perform magnetic resonance. And again, we have to evaluate the risk of functional impairment, airway obstruction, ulceration, and risk of disfigurement. There are or decision points. And in case of evidence of infantile hemangioma, the same points we have already discussed. But if you don't have evidence of infantile hemangioma, you have to search for a new diagnosis and consider again a magnetic resonance, or if you have doubt of the nature of benign or malignant nature of the lesion, you have to perform a biopsy in case of uncertain diagnosis. Like in the picture you see on the right side, it was unfortunately a sarcoma. There is also particular circumstances. For example, if you have a risk of functional impairment, you have to check, in particular, when you have orbital or auricular infantile hemangioma. If you have infantile hemangioma of the lip or on the hand, for the lip is very important, especially when you are ulcerated, because if you have pain, you cannot perform good suction for breastfeeding, and on the hand for the use of the hands and this particular ability. In some cases, magnetic resonance also is necessary to evaluate the relation between the infantile hemangioma and the neighbor structures. In case of when you suspect airway obstruction, in particular when there is the beard distribution and respiratory symptoms, we have to consider laryngoscopy. In case of hepatic infantile hemangiomas, we have when there is a diffuse there are diffuse infantile hemangioma lesion on the liver, it's important to test thyroid function, because there is a particular interference of the infantile hemangioma on the thyroid hormones. And when the infantile hemangioma is particularly voluminous, also it's important to perform cardiological evaluation and to test the thyroid function too. So we come back to the treatment of rare infantile hemangioma. So when we have this condition, that as I told you, there are decision points. If we have a functional impairment, airway obstruction, ulceration resistant to standard treatments, and risk of disfigurement, then if there is no condition like this, we have only to evaluate the regression, there is spontaneous, and then eventually at the end of the regression, we have to treat sequelae with laser or surgery. If we have these conditions, we have to treat the patient. The first line treatment, of course, is propranolol. That must be, the dosage is 2-3 milligrams per kilogram per day in 2 divided doses. It is very important to evaluate the response within 1 month. This because usually we have 98% of response, maybe partial response, but in almost all the cases we have response in infantile hemangioma. So if we have no response, if we have a response, we continue treatment till the end, and then we consider at the end of the treatment again the treatment of the sequelae. But if you don't have response, we have to re-evaluate the diagnosis, because it's very rare not to have response when you have infantile hemangioma treated with propranolol. So if we confirm infantile hemangioma, we have to decide for a second line treatment that must be corticosteroid. It was the first line treatment in the past. Then sirolimus is emerging treatment in the literature. Interesting, it was in the past was the second line after corticosteroids. Nowadays, we almost never use vincristine. And then surgery may be useful in very particular selected cases. For example, if you have an infantile hemangioma with a large ulceration and pain, you may consider surgery as also in particular case as first line treatment. And embolization usually we use only when there is an hemodynamic effect of the lesion in combination with surgery. And now we talk about hepatic infantile hemangioma. And if we don't have risk of a hemodynamic effect, you don't need to treat this patient. So we can only evaluate the patient after regression of infantile hemangiomas. If we have risk of hemodynamic effect, the risk is sufficient to make the treatment. So we have to treat the patient with propranolol with 2-3 milligrams per kilogram per day in 2 divided doses. It depends on the experience of the centers. Some centers are suggested from the company who produced this drug. Maybe you can start with 1 milligram per kilo, and then you increase every week, and the treatment doses that could be 2 or 3 milligram, depending on the response. If you have response in 2 milligram per kilogram per day, you can stop on 2 milligram. If you don't have a sufficient response, especially in very important localization, for example, on the localization on the eyelid or localization on the airways, then you have to go on 3 milligrams, of course. But we come back to the hepatic infantile hemangiomas. If you have hemodynamic effect, of course, you have to treat the patient. And also to have, it is very important to consider also an embolization prior to the treatment with propranolol. You have to consider that propranolol have also a cardiac effects. So if you have a cardiac failure, if you start directly propranolol, you can have worsening of the cardiac failure. So it's important maybe to reduce the vascularization of the lesions and then to start immediately after propranolol. Again, it's important to have evaluation of the patient after 14 days. In this case, because there is a very important situation with, especially if you have an hemodynamic effect. And if you have a response, you continue the treatment and the follow-up of the patient as normally. But if you don't have response, again, you have to re-evaluate the diagnosis. And maybe you have to perform also some blood tests with tumoral markers and to exclude also the possibilities of metastatic lesion, for example. But if you have a confirmation of infantile hemangioma, again, you have to consider a second-line treatment with corticosteroids, sirolimus, vincristine, or with surgery, maybe before with embolization. Yeah, usually just a common on corticosteroids. Usually there you have almost always response to corticosteroids, but it's very difficult to have to manage the disease only with corticosteroids, because if you have to prolong the treatment after several weeks, after 1 month, you will have probably complications with steroids. So that's why when you need a second-line treatment, it's very probable to have the necessity to associate also another treatment together with corticosteroids. And now we talk about face syndrome. You can have abnormal cerebral arteries, or not only cerebral arteries, but also we have to have also, if you are aortic coarctation. In this case, we have to discuss with the cardiologist, of course, and also with the neuroradiologist. And in this case, as soon as possible, we have to start the treatment with a low dose of propranolol. It's better to have a low dose, in particular in some situation. For example, if you have stenosis of principal intracranial arteries, or if you have incomplete Willis polygon arteries, or if you have signs of chronic ischemia, cerebral ischemia. In those cases, it's better to have a reduced dose, because if you reduce the blood pressure, you can have a worsening of these conditions, and you start the propranolol on the lower dosage, and then you have also to treat the patient according to the other specific abnormalities that you can find associated to the face syndrome that we have seen before. And it's very important also to consider to repeat MRI depending on the risk of stroke. This is very important to discuss with the neuroradiologist. When you don't have abnormal cerebral arteries, and when you have pelvis lumbosacral syndrome, you can treat the patient with the normal dosage of propranolol. There is 2-3 milligram per kilogram per day in 2 divided doses. And you have also to treat also in this case the other specific abnormalities that you find associated with the segmental infantile hemangiomas. For example, annus imperforatum, or you can have dysraphism, or tethered cord, or other kind of malformation associated, as I've seen before. And also you can have a very low weight premature child. You have to consider the corrected age of the patient. You have to calculate also prematurity. You have to also to consider if you have comorbidities. You can have also particular the patient can tend to have hypoglycemia, for example, must be considered. You have also you have always to check before start treatment of propranolol. You have to check of course, the glycemia if it's normal, and you have to consider also if there is low compliance of the parents. You can have a particular condition, a very low social cultural condition of the parents, and in this case it's very important to start the treatment as an inpatient as soon as possible, of course, and to start the propranolol also with a very low dosage, 0.5 milligram per kilogram per day in 3 or more divided doses. For example, in the patient we have on the right side, it was premature, and he had a lot of problems with hypoglycemia. With propranolol was very difficult to increase the dosage of the drug because of hypoglycemia. And another comment, a particular situation is when you have ulceration, because ulceration, especially when ulceration starts during propranolol treatment, in this case there is a lot of discussion in the congresses and also some proposal in the literature, but it is not, we have not completely clear knowledge of what to do, but you have to consider there is an expert opinion to lowering the dosage because there is the hypothesis that propranolol can reduce vascularization of the ulcers and also increase ulceration, and so maybe in conflict the treatment of the hemangioma with the treatment of the ulceration. But you also have there is a very particular hypothesis also, because you have to consider that ulcerated hemangioma may be also an indication for treatment with propranolol. So there is a lot of discussion. We need more study about it, and we can have more data in the future to decide what to do in these cases, probably. So we are now on the conclusion. So in the absence of high quality randomized clinical trials in the field of the rare disease, it's clear that expert consensus opinions remain the best tool to improve the quality of management of the patient. Even if they are considered the last level of evidence, the fifth level, it is clear that they are the best way to answer to clinical queries, clinical question for the patient, to match the problems of the patient. We use a structured process that allows participants to decide which topics require further discussions. And this is very important to have equal participation for all the group members in conflicting content. This is guaranteed by the facilitators, and all recommendations of this expert opinion were unanimous because there is no limit of time. So we continue discussion until the end when we have unanimous decisions. The only limit of our process, we can say that, is the absence of anonymity. But this is a little bit different from the Delphi method that is another kind of method for consensus. In Delphi method, there is a complete anonymity, but there is no such kind of dynamics and discussion and collaboration between the expert in deciding what's the final statement. So that's why we decided to use our method. And finally, it's very important that the quality of the statements of the expert panel depends on also the member skill. And in this case, the skill was certified by the Assembly of the National Multidisciplinary Reference Centers that has been endorsed by their governments. to the EAR network on the basis of well-defined criteria that are published on the website of the ERN. And so now I finished, and hello from all the members, not all the members, but the members who participated to our last board meeting. And thank you for your attention. I have finished.
Thank you very much, Andrea. That was a really great presentation. So now I'd like to open it up to any questions that any of the participants they may have. I see that there was, I think it might have been a comment that agreed with you. Hepatic hemangioma usually answers good to propranolol, so I'll start with propranolol, and only if not response, I'll consider embolization. So I think that was a doctor saying that what he does.
Yes, yes, of course. We consider embolization only. I have said if you have cardiac failure signs. In this case, the problem is that propranolol can make worsening of the situation of the hemodynamic situation. So that's why we consider embolization. But otherwise, we directly start propranolol. But what we have said is also that you don't have to treat all cases of hepatic hemangioma. This is very important because only if you have the suspicion that may have in the future an hemodynamic effect. Of course, when you have hemodynamic effect, there you have the indication to start the treatment. Otherwise, you don't have to treat a very small, not so diffuse lesions with no possibility of hemodynamic effect. In this case, you can simply follow the patient.
Okay, thank you. Another question is, in the last World Congress of Pediatric Dermatology, an issue was marked, children who have regrowth of IH during the treatment with propranolol. How would you manage it?
Okay, thank you for the question. Yes, this is very interesting. That's why if you see what is written by the company, they suggest to perform a very limited period of treatment. Usually they suggest to perform 6 months of treatment, but there are also publications that suggest to start the earliest as possible the treatment, but to continue the treatment until the age of 1 year. So, because you can have this problem, if you start very early, you will have a very nice effect of the treatment, but you will finish very, very early. You may be in a phase, in an age when infantile hemangioma can still regrow. So you could have also recurrence, and it's demonstrated that in cases when you make prolonged treatment until the age of 1 year, you will have less recurrences. If you have recurrence after 1 year, you have to discuss, of course. It depends on the localization, in my opinion, of the hemangioma and the importance of the case. When you have, of course, a localization on the eyelid, and maybe you have a partial closure of the eyes and the problem with the visual capability, or if you have, of course, very profound or airway infantile hemangioma, you have to prolong the treatment. For example, it depends also on the experience of the center, but in our center, when you have very profound lesions, if there is a very important disfigurement, or when you have involvement of the airways, we prolong until the age of 18 months of life, because we don't want to have the risk of recurrency. When you have a superficial lesion that usually do not grow after 1 year of age, and you can also have a recurrence, and you can decide if to treat again the patient, there is no problem, we stop at the age of 1 year. So the standard could be to treat until the age of 1 year. In particular condition, you directly continue, the treatment. If you have recurrence when you stop at 1 year, you have to decide in a multidisciplinary approach if you have to retreat the patient, or simply you can only treat the sequelae of the infantile hemangioma. This is our experience.
Okay, great. There's another question asking, what is your opinion about neurological side effects of propranolol? Is it dose related?
This is a very hot argument, but there are in the literature some papers who hypothesize this effect on neurological complication, but there are also other very large series of cases of children that are at school. So after the age of 6, they have no kind of symptoms, no kind of any kind of problems at school, and there is no tests, psychological tests that has demonstrated on a statistical point of view that there is a complication, neurological complication in children that has been treated with propranolol. If you are talking about the risk of cerebral ischemia in phase syndrome, this is another, of course, kind of question. In this case, of course, could be related to the dosage, because in these cases, if you have a higher dosage of propranolol, you will decrease the pressure. And if you decrease the pressure when you have stenosis of principal arteries, or when you have particular situation of chronic ischemia or incomplete Willis polygon, in this case, you can have worsening of ischemia, cerebral ischemia. So in these cases, of course, we think that could be dose related, the neurological side effects.
Okay, thank you. And what is your opinion about timolol, with or without propranolol? And what about new selected blockers?
Okay, about timolol, I think it's very useful in very selected patients, but the lesion must be very, very thin, maximum 1 millimeter, and not very large. If it's a very large lesion, for example, we don't have complete data on that, statistical data to make a conclusion. But if you have a very wide lesion, you can have absorption. You have to consider timolol is 10 times more effective than propranolol as a head effect, and so you can have side effects. Personally, I had, for example, a patient that I treated with timolol for not very small lesion, and the children started to wake up during the night and have probably nightmares. He was crying during the night because and this is one of the most frequent side effects of beta blockers, and so I stopped the treatment. So must be very selected, but what I think it is very important not to use timolol to avoid propranolol. This is very important, because in this case there is the risk that you will not start propranolol when is indicated. So sometimes you have time to organize also the treatment with propranolol. If the lesion is thin and not so wide, I give also timolol. In the meanwhile, waiting for a day hospital, for example, to start propranolol, or otherwise as a single treatment only with very thin lesion, not so wide. And about a new beta blockers, they're very interesting. For example, you can use atenolol or other beta blockers, they are very useful because in particular very selected cases, because these beta blockers maybe have the same effect on the airway. So they are very important in case of when you have asthma. In this case, you can consider also as a second line this new beta blockers. But is very important to recognize that propranolol is the only one that has sufficient literature, so it must be the first line treatment. There is no discussion on that. It is the only drug on the market with this specific indication. So it's nowadays there is no discussion that propranolol must be the first line option to treat infantile hemangioma when systemic treatment is indicated.
Thank you. And just a question about the propranolol. When you say 2 or 3 milligrams, does that depend on the location?
Yes, it depends on two variables. If there is response, you can stop normally on 2 milligrams in almost all the cases. But if you have particular localization, when you want to have a very fast response, you can consider 3 milligrams. For example, if you have an hemangioma, infantile hemangioma of the upper eyelid, you want to be the fastest possible to have to open the eye. And in this case, we usually point to the 3 milligram treatment, not directly. Obviously, you must have the step to start. We usually start directly on 2 milligrams because our cardiologists are very friendly with the propranolol, and they see the patient together with us when we start propranolol, and they allowed us to start on 2 milligrams. And when we want to go to 3 milligrams, in these cases, we after a few days we repeat cardiological consultation, and we go to 3 milligrams in a particular condition. That might be, in particular, the eyelid infantile hemangioma, and also, of course, the airway obstruction. Also, in this case, you want to have the fastest response you can have. So that's why 3 milligrams in these cases is better than 2.
Thank you. And do you perform cardiologic evaluation before timolol treatment?
If you make very strict selection of the cases, and now, as I told you, I only treat a very small, very thin lesion and not so wide. I don't perform cardiological evaluation. Usually, in case of larger lesion, I go directly for propranolol, and so I don't need to. I don't need on the literature. There is no clear decision of the moment to adopt, and so I don't perform in selected cases cardiological evaluation. But if we talk about cardiological evaluation, we have also to recognize that the panel of experts, and Lali, who make the question, is one of these European experts. They suggest that it's not mandatory to have a cardiological evaluation also for propranolol on systemic treatment, but of course it depends also on the experience of the experts. For example, in my center, the dermatologist is the one who coordinates the team of vascular anomalies, and so we don't want to start cardiological a drug that has cardiological effect without cardiological evaluation. This is our experience, but you can decide. So of course, depending on your experience, if you are a pediatrician, for example, you can decide to prescribe alone, Of course, a cardiological evaluation must be performed when you have some problems on the history, family history of the patient. For example, if you have a history in the mother of lupus, you can have, for example, also some consequence on the newborn. You can have also some particular condition that make the child to be at risk for particular arrhythmia. So in these cases, you have, for example, is mandatory to have cardiological evaluation. But in our center, we always have a cardiological consultation before propranolol treatment.
Okay, great. Another question on propranolol. Is it safe to give propranolol in the evening, and why do you divide it in 2 doses?
We divide it into doses because that's what is the result of the international study about propranolol for the infantile hemangioma, and but also cardiologists, I think they use 2 divided doses of propranolol. So this it depends on the life of the drug and systemic drug, that to have a better steady state of and to have a continuous level of the concentration of the drug in the blood, is better to have 2 divided doses. We change it in very particular situation. For example, when there is a high risk patient, in the case of FACE syndrome, or in the case of very low birth weight, or when you have problems of hypoglycemia, in this case we can also divide in more than 3 divided doses, in order to don't have to have the minimum change of blood, because the more are the doses, the more is constant the level, of course, of the drug on the concentration in blood of the drug. That's why we use 2, and in particular situation we use 3 or more divided doses.
And in the evening, there's no problem to give it in the evening?
No, there is no problem. But as I told you before, some patients, this is very frequent, may have problems during the night, because it's very frequent, and the adults told us that it's very frequent to have nightmares also when you use beta blockers, and to have problems in sleeping. So also children, they have very frequent, they cry very frequently also during the night when they stay asleep, for example. In these cases, when you have to increase the dose, and if you don't have and you have to choose what to increase, and then in these cases, this is our experience, we prefer to increase the first dose instead of the second one. Or in this case, we can also divide in 3 doses, and we have to have more dosage in the first 2 dosage of the morning and afternoon, and less dosage in the dosage of the evening. This in particular, just when we have these particular problems when in the sleeping of the child.
Great, thank you. And we have a last question. In my experience, if the response is good with 2 milligrams per kilogram per day, in many cases this dosage can be maintained without further increase with the gain in weight of the child. What are comments from your side?
So without increasing, based on the weight of the child?
Maintaining 2 milligrams per kilogram per day, in many cases it can be maintained.
So, we do not, we always, if you do that, you are decreasing the dosage, because the pediatrician teach us that the dosage is in children, the dosage is the milligram per kilogram. So if the child increase with the weight, if you do not increase the dosage according to the weight, you are decreasing the dose. It doesn't make sense, in my opinion, because if you have a nice response up to 2 milligrams per kilogram per day, and if you don't have side effects, you have literature on this dosage, and you have also expert opinion about this dosage. Why to increase? You should make a study to suggest a lower dosage. If you want to reduce the dosage per kilogram, we should make some dosage. Maybe in the future we can decide, if we have more data, that we can have a lower dosage. But if you consider the international study that initially was 3 compared to 1 milligram, in this study, there was the first international study on propranolol, they confirmed that 3 milligrams has a lot better results on a statistical point of view than to 1 milligram. Then in the literature, we had a lot of data and expert opinions about 2 milligrams that was sufficient to have results that are similar to 3 milligrams. But it's not the same if you compare 3 milligrams with 1 milligram. That's why usually we cannot suggest to have a dosage lower than 2 milligrams. But we have lower dosage, lower than 2 milligrams, only in particular cases. As I told you, when you have a phase syndrome with high risk, if you have ulceration, and we are afraid that propranolol may interfere with the healing of the ulcer, in particular cases, we have reduced the doses, but in very, very selected cases only.
Great, thank you. Okay, so yeah, he was just saying that it's not a study, but a result of daily practice. And so, as you were saying, it's better to wait for more studies before recommending that. Okay.
Okay, yes, I agree with him. We everyone of us make a lot of things on the basis of our practice, but as I told in the presentation, we have different kind of information. Now we have randomized clinical trials with scientific and statistical demonstration of the results, and we have also opinions, but in the case of the opinions, it should be better to follow expert opinions and not our own opinions. But we are free to follow our opinion, but in this case we are alone. All responsibility is on ourselves, but we can do it.
Thank you. I think that's the last question, unless anyone else has some final questions to add, which is good because we're coming up until the hour. Just to mention, the pathway that was discussed today can be found on the VASCERN website on the VASCA working group page. I can put the link quickly for all the VASCA patient pathways. They're now in the chat box, and you can find them on the website. This is the first webinar of the series that will be on the different diagnostic and management pathways for the vascular anomalies groups. And the second one will be in December on lymphatic malformations. So I don't see any other questions. So I'd like to thank Dr. Andrea DIOCIAIUTI for a wonderful presentation on the diagnostic and management pathway for infantile hemangioma. It was very, very detailed and very interesting. Thank you to you.
Thank you, Natasha, and thank you to all the others for your attention.
Great, and Again, if you want more information on VASCERN or the VASCA Working Group, you can find it on the VASCERN website, as you see on the slide here, vascern.eu. And please follow us on our various social media accounts, Twitter, Facebook, YouTube, LinkedIn. This recording of this video will be on the YouTube channel shortly. So you just need to check back on the YouTube channel for that. And yeah, we wish you all a very nice evening and thank you all for attending.
Thank you. Bye-bye.
Thank you. Bye-bye, everyone.